Shut this door. We are going to make sure everybody is on mute. It is 10:05. I did say I was going to wait just a few minutes. So again, welcome to our Diabetes Awareness Seminar. This is our third annual. We are Stonebridge Healthy Community Outreach Initiative. And our founder is very wonderful, Miss Ali Smith. Stonebridge Health Community Outreach Initiative was organized by our illustrious founder, Miss Ali Smith. She's a retired school teacher. The organization was founded in memory of her parents, Penny and Willie Smith, who were the proud parents of 12. In 1963, unfortunately, Miss Ali's father passed away at the age of 54 due to complications with diabetes. Miss Ali herself was diagnosed with diabetes, along with 9 of her 11 siblings, 3 of which have passed away. By aggressively changing her diet and developing a regimen of taking vitamin supplements and incorporating exercise into her daily routine, Miss Ali was able to successfully manage her illness, rendering her a better quality of life. Due to her success, Miss Ali became very passionate about teaching and helping others diagnosed with diabetes or at risk to change their habits and develop healthier lifestyles. And this organization was birthed from her passion. Stonebridge Healthy Community Outreach Initiative, our mission is to bring awareness, prevention, and restoration of, lifelong health solutions for diabetes and other chronic conditions to families and communities. Our goal is to educate individuals by providing quality information and services that address individual needs in order to manage, prevent, and/or reverse chronic conditions. Our primary objectives are to help participants modify their lifestyles through educational resources such as plant-based nutrition, economic stability, physical activity, spiritual wellness, social connectedness, mental health, and creativity. Why are we interested in doing all of these things? We want to be sure to bridge the gap between education and health disparities, as well as to provide access to healthcare and affordable quality food. To empower communities by providing them with the tools that will aid them in making the best lifelong decisions and prevent the development and worsening of chronic conditions. To teach individuals the dynamics of meal preparation as part of their life skills and self-management training. To creatively inspire children to make healthy food choices during their developmental stages, and to help people heal from their chronic diseases by providing them with resources. To start off our presentations, we have our very favorite, Dr. Scott Goodwin, who has participated with us in, I believe, all 3 of these so far. So he's definitely a fan favorite. Dr. Goodwin is a practicing general endocrinologist at Franciscan Olympia Fields. He is dual board certified in internal medicine and endocrinology, diabetes, and metabolism by the American Board of Internal Medicine. He is a graduate of the University of Missouri School of Medicine. He completed his internal medicine residency through University of Arizona in Phoenix, where he served as chief resident and junior faculty. He completed his endocrinology fellowship training at Washington University in St. Louis. He has a passion for diabetes care and helping those with diabetes lead healthy, fulfilled lives. Dr. Goodwin, I am going to make you co-host so that you can share your slides, or Tara, are you going to pull those up? In either case, I'm going to stop sharing now.
Okay.
Can we all give Dr. Goodwin the honor of presenting with our mics off? Hold any questions until the end. Feel free to input them into the chat, and we will give him the opportunity to address questions at the end of his presentation. And from there, we welcome Dr. Scott Goodwin.
Thank you. I appreciate this. Good morning, everybody. Hopefully everyone can hear me.
Dr. Goodwin, I can bring up your slides if you want me to.
I was trying to share my screen, but I think it's unlocked.
Okay.
I just unlocked it.
No,
for you.
I just, okay, I can pull up, I can do my screens.
Okay.
Let me pull it up and then see. Can everyone see that okay? Is it coming up on
Yes.
your end?
Yes.
Okay. All right. Well, again, good morning, everybody. I'm Scott Goodwin. I'm one of the endocrinologists here in Olympia Fields, and I have the privilege of talking with you about a topic that I'm very passionate about, and that is diabetes. So with this short presentation, I'm basically going to go over three main points. One is we'll define exactly what diabetes is so that we're all kind of on the same page of what we're talking about. The second portion of the presentation will be kind of going through why diabetes control is so important, how diabetes can negatively impact our lives, and lastly, we'll end the presentation with what are some of the things we can do through lifestyle or medications to control diabetes so that we can all live healthy, productive lives. So the first question, what is diabetes? So diabetes is defined as a chronic condition that results in high levels of sugar or glucose in the blood. And if we kind of think of our body as a machine with gears, we take in food or our body produces sugar or glucose, and that glucose then needs to be transformed over into energy for our body to use. And if we think in that premise, insulin is like the oil that's needed by our gears to move. So the insulin will lubricate our body, our cells, to help that glucose or that sugar be absorbed by the body and transformed over to energy. So what diabetes happens is, in diabetes, there's really two main problems that can happen. One problem is where the pancreas, which should produce insulin, becomes unable to produce insulin. So there's a lack of insulin, there's a lack of that oil. And that term is called type 1 diabetes. It used to be called juvenile diabetes. It's now termed type 1. There can be a second problem though, and that's where the body is still able to make some insulin. It's just not enough. So either it's the pancreas is producing insufficient amounts, or the pancreas is producing actually a lot of that insulin, of that oil, but the body is resistant to it. And that form is called type 2 diabetes. It used to be called adult onset diabetes. Again, now type 2. So those are the two main problems that can happen with diabetes. We now know, though, that it's not all about insulin. There's lots of other problems or defects that can happen in the body for various reasons that can make the blood sugars go high or make someone develop diabetes. And I'm not going to go into too many details about these. Just know that if you do see, if you have blood sugar problems or family members have blood sugar problems, that you see a physician, that physician is going to be able to do cardiometabolic testing, and really just through their education, training, experience, will have some insight on what other possible defects may be going on and can address that through advisement on medicine changes or lifestyle changes. Diabetes is a big problem in the United States. So this graphic, I do like how they broke it down, but just know this is an old graphic. So this is from 2015 or 2017. In today's day, there's estimated 32 to 34 million Americans with diabetes. So not the 26 million, it's more. So the numbers really aren't that important, but I just want to kind of break down just as kind of an eye opener that there's a lot of people that have that have diabetes, have blood sugar problems, but either have not been formally diagnosed, meaning people showed up, they had testing done, the tests show they have diabetes, but there was a lack of follow-up or a lack of insight on that person. So they are living with diabetes and don't know. And there's a vast majority of people that have diabetes, know they have diabetes, are on medicines for diabetes, and still have uncontrolled sugars, have uncontrolled diabetes. And in terms of percentages, about 1 in 10 people in the United States have diabetes. 1 in 5 people have diabetes and don't know that they have diabetes. And because there's a vast majority of people that have diabetes that haven't had control of sugars, it costs the United States a lot of money in treatment of the complications. So it's estimated from 2019, this is pre-pandemic, it's estimated that the United States spent $327 billion on diabetes care and complications care. So that's a lot of money that we as taxpayers are going to be shelling out eventually to help care for this condition, unless more is done to get better control. This is just another graphic that shows the prevalence of diabetes from the mid to late 1950s to 2015. Back in the 1950s, diabetes was only about 1% of the population. And today's, it's around 7 to 8% of the population, or I guess almost 10% now. The one thing that I would want to kind of point out that I think is really interesting is that from 1950s to the mid 1990s, the slope of diabetes increases was fairly flat. I mean, really for 40 years, the prevalence of diabetes really went from 1% to, maybe 2%. It wasn't really that much of an increase. And then from mid 1990s to now, it really shot up. And part of that reason actually isn't anything bad. It's actually good. And it means that people that have diabetes today are living longer. And there was a medication breakthrough that we'll kind of talk about later on in this presentation that was developed in the mid 1990s that resulted in it resulted in a 40 to 50% reduced risk of death from diabetes or diabetic complications. And so nowadays people are living longer with diabetes, and that's one of the main reasons why the prevalence of diabetes is increasing. All right, so now we kind of know the scope of the problem of what diabetes is. Let's move on to what is a high sugar? Sugar, what's considered high? So let's start with normal. So there's a couple of ways to check blood sugar. One is we can check a fasting blood sugar, a sample of blood that's taken when someone has not eaten or drinking anything for 8 hours. Normal should be a blood sugar that's 99 or less. Another way to test is called a glucose tolerance test, and that's where we give someone a standard dose of a carbohydrate snack and then check their blood after that snack, an hour, hour and a half, 2 hours later. And if we do that test, 140 or less is considered normal. And then there's another test that we do that's called a hemoglobin A1C or an A1C test. And this test is nice because instead of telling us what someone's sugar was at the time of the test, it gives us an average of what someone's sugar might have been over the past 3 months or so. So it's kind of it's I think a little bit better of a test in that it lets us know, again, how sugars on average have been running for the past few months. And so that test is called hemoglobin A1C. It's resulted as a percentage, and that percentage can correlate to an average blood sugar level. And normal would be a number that's 5.7 or less. Diabetes is when the A1C is above 6.5, or a fasting sugar above 126 repeatedly, or a blood sugar that's over 200 repeatedly after a standardized glucose tolerance test. And there is the gray zone, or in this case, I guess it would be a yellow zone, of people who have sugars that aren't quite normal. They're not high enough, though, to be considered diabetic. And these people are termed pre-diabetic or at risk for developing diabetes. And this is really the group that I'm very interested in really promoting a healthy diet, exercise program, a education program, because the whole point should be to really aggressively inform people that are in this yellow zone to hopefully reverse course, get them back down into the green zone and prevent them from going on to develop diabetes. Why do we want to control sugars? So first and foremost, it would be prevention of some poor symptoms. When blood sugars spike high, people don't feel well. The most common symptoms would be someone that's, when their sugars go high, they feel like they have to urinate a lot, they feel very thirsty, they feel extremely tired. They may lose weight, and it may be welcomed weight loss. Oftentimes, though, it's unintentional. They're not changing their diet or their exercise program, and yet they're losing weight. And that can be a marker of the sugars just going way too high. There's lots of other symptoms, though, that can happen. And so that's one of the reasons why we want to get the blood sugars down, is to limit some of these symptoms and improve someone's quality of life. There are other chronic symptoms that can happen, or not really symptoms, but chronic diseases that can happen. High sugar, sugar is a starchy, sticky substance in the blood. And if it is in a high concentration in the blood, it can lead to damage to other organs in the body. And the three most common sites that can be damaged when the blood sugars are high are the eyes, when high sugars, diabetes affects the eyes, it's called diabetic retinopathy. And diabetic retinopathy can lead to blindness. And actually in the United States, that is the most common cause of blindness. Diabetes also can negatively impact the kidneys. In the United States, diabetes is one of the leading causes of kidney failure and people needing hemodialysis. And lastly, diabetes can affect the nerves in the body, including the nerves that go down to the feet. And that can cause symptoms like numbness and tingling, and even a burning sensation or painful sensation in the legs or in the feet. Over time, it potentially can lead to someone getting an infection or an ulcer to develop that can be difficult to heal, and it can lead to amputations. And again, diabetes is one of the leading causes of amputations in the United States. High sugars can also increase the risk of having a stroke and a heart attack. And so, again, it's important to prevent the development of these organ dysfunctions by getting better control of the diabetes and lowering the sugars down. So what are some of the ways that we treat diabetes? How can we control the sugars to prevent some of those poor symptoms and those internal organ complications from developing? The first is lifestyle modifications. It always starts with a good diet and exercise program. And I think later on in the series, we're going to be hearing from nutritionists, and I think even a chef, to kind of talk more about a healthy diet plan. Of course, there's medicines that are directed towards lowering sugars. And then there's also medicines that are used to help limit some of the other cardiometabolic complications that can happen with diabetes, and to help someone, or to prevent someone from developing heart disease. And then this should probably go without saying, but also tobacco. Tobacco is extremely harmful for the vascular system. Diabetes is harmful for the vascular system, and both of those together do not mix well. The complications of a person that has diabetes and also smokes it nearly doubles the person's risk of developing complications. In terms of lifestyle modifications, generally someone would want to do a diet that's restricted in simple sugars as well as salt. Want to stay physically active, and most physicians would consider that to be 30 minutes a day, most days of the week, of doing some sort of aerobic activity that gets the heart rate up. We want to try to limit the weight that we carry, especially in our midsection. And we want to try to if we are overweight, we want to try to gradually lose weight to try to reach and maintain a healthier body weight. In terms of diabetes medicines to lower sugars, it really depends on the form of diabetes someone has. If someone has that type 1 diabetes where their body is not able to produce insulin any longer, the primary treatment is giving insulin back. We give back what the body isn't making enough of. If someone has type 2 diabetes, there are medicines that can be used in the form of pills, non-insulin injections, as well as insulin to help lower blood sugars, as well as combat some of those other defects that can happen with diabetes. And oftentimes medicines are used to not only treat the sugar, but also can be used to help reverse the underlying problem that's happening with diabetes. When someone has diabetes and we're using medicines to lower their sugars, we don't have to lower the sugars to normal. We really just have to lower the sugars, but they don't have to be to normal. And again, as a reminder, someone that does not have diabetes, what normal blood sugars would be a fasting sugar that's 99 or less, a pre-meal sugar that's 99 or less, or if someone were to check their sugar after they ate a meal, it should be 140 or less. If someone has diabetes, we do not have to get them to this goal. Really, the primary treatment of diabetes sugar control is not to normalize the sugar, it's to prevent the complications that can happen with diabetes, to limit the poor symptoms and to limit the eye problems, kidney problems, nerve problems in the feet, heart attacks, strokes, all those bad things. And to limit those bad things, we don't have to get the sugars normal, we just have to get somewhat better control of the sugars. And that generally, the American Diabetes Association has guidelines that I wrote down, and that's usually the ones that I follow for most people. And that would be a fasting or pre-meal sugar that's 80 to 130. And if someone were to eat their sugar after the meal, should be less than 180 an hour after eating. So again, that's higher than normal, but it's not high enough that most people would develop problems. One of the other treatments that's becoming standard of care now for diabetes actually doesn't go after sugar at all. It goes after cholesterol and heart disease. So it's now standard of care that someone that has diabetes and they're aged between the years of 40 and 75, even if their cholesterol is normal, they should be on a medicine to lower the cholesterol. It's called a statin medicine. And the reason for this is that this class of medicines, the statins, have been shown to reduce the risk of heart disease by nearly 50%. They cut whatever someone's risk of having a heart attack is, they cut that down by 50%. And this is one of the reasons why the prevalence of diabetes has gone up. These statin medicines really became about in the mid-1990s. And since then, people are living longer. They really do save lives. So this is an old graphic. This was published in 2004. So it's about 10 years after the statins were developed. And in this study, they randomized people that had diabetes that were over the age of 40 with diabetes. And these people all had a baseline bad cholesterol that was less than 160. So traditionally, 160 was not considered a high cholesterol at all. So these effectively were people with diabetes that did not have high cholesterol. And they were given a low dose of a statin medicine. And they were followed for a median of 4 years. And to kind of orient you on the x-axis here is the years. So year 1, year 2, year 3, year 4. And then the y-axis is the percentage of these people that developed a heart attack or stroke, cardiovascular. Actually, these are just people with heart attacks, coronary artery disease. And the people that were treated with the cholesterol lowering medicine, again, even when their cholesterol wasn't high, they had a significant drop in the incidence of heart disease. Actually, really early on, even at year 1, the graphs started separating. And by year 4, it was a 37% reduction risk. And now it's standard of care that someone, even if they have normal cholesterol, if someone has diabetes, we don't use a low dose cholesterol medicine, we use a moderate to high dose. And by doing that, we can drop someone's risk of having a heart attack by 50%, which is pretty remarkable. There's no other medicine or lifestyle change that does that. Another aim at prevention of complications from diabetic issues would be controlling blood pressure. For most individuals, that would be a blood pressure that's less than 140/90. Sometimes, actually a lot of the times, it needs to be a little bit even lower than that. And there's two main classes of medicines that are used to help lower blood pressure if someone has diabetes, because both of these medicines have been shown not only to help lower blood pressure, but they also can help prevent the progression of kidney disease. This was another old study that was published in the 1990s. And this looked at people that had diabetes and whether, in terms of heart disease, prevention of heart attacks and strokes, what was more important? Was it more important that we really work to control blood sugars, getting a hemoglobin A1C less than 7%? Or is it more important to control blood pressure? And at the time, they defined blood pressure control to be less than 150/85. And again, in today's term, we have data that shows the blood pressure should be even lower than that. But even with that higher blood pressure marker, there was a significant reduction in the rates of fatal heart attacks, so people who died from a heart attack, non-fatal heart attacks. So these are people who had a heart attack but survived, strokes, and heart failure. Significantly more, the yellow bars are people with tight blood pressure control. Significant reduction, close to 60% reduction in stroke risk versus sugar control. Oh, sorry about that. So sugar control, tight sugar control did result in lowering of heart disease, heart attacks, and heart failure. Interestingly, it wasn't really shown to limit stroke risk. There may be reason for that, but you know, in terms of heart disease, there was a lowering of heart disease, but much more important is making sure we control blood pressure. So that's a summary of this short talk. So again, just to kind of review, diabetes is defined as a high blood sugar, and it's unfortunately a common condition that affects nearly 1 in 7 Americans. Having uncontrolled diabetes can result in poor physical symptoms, and it can lead to an increased risk of having organ complications. And that's why effective control of the diabetes is so important. And we can control diabetes through lifestyle modifications as well as medications to improve blood sugar, blood pressure, and cholesterol. And by doing so, us living with diabetes can live happy, full, and healthy lives. And that is my presentation. I'm going to open up the talk to any questions that someone would have.
Feel free to add your questions in the chat, or you can also raise your hand using the reactions and we will acknowledge you. Thank you very much, Dr. Goodwin, for that very interesting discussion. I have a question while everyone else is formulating their questions. Do you think that one of the reasons that there's a correlation between the cholesterol issue and diabetes is because they are both vascular issues? Like maybe there's something more that we just haven't explored yet in terms of the cause or the treatment of diabetes. Do you know? Does that make sense?
Yeah, so one of the issues that happens with diabetes is that when the sugars are high, again, sugar is a sticky, starchy substance. So if it's floating around in the blood, it's going to be sticking against our vessel walls and coating around our blood cells. And that can cause inflammation. And what happens with heart disease is if someone has a heart attack, there's plaques that are built up in the artery walls, and then those walls, that plaque can rupture, and it can send out little deposits of fat and other that plaque material, and it gets lodged later on more distally into that vessel where the net vessel maybe narrows a little bit, and then it blocks off the blood flow, and then that's what causes the heart attacks or a stroke. And people that have high sugars, that sugar increases inflammation, and it's that inflammation that kind of eats away at that plaque lining and can lead to that plaque rupturing. So when in terms of the statin medicines, those medicines lower cholesterol, but they also take plaque away from the artery walls. So if there's less plaque being built up in the artery walls, the walls flatten out. Even if the sugars are higher, and even if there's more inflammation, if those plaques were to rupture, there's going to be less of that plaque that's going to end up occluding the vessel later on, causing a heart attack or stroke. Yeah, does that kind of answer the question? Sorry, I don't know if I went off on a tangent.
Answers the question. That makes complete sense, because if both of those things are sticking to the vascular walls, they're definitely going to have that comorbidity. So that makes perfect sense. Thank you very much. Did anyone else have any more questions?
I do.
Go ahead.
Good morning, Dr.
Goodwin.
I thought your presentation was right on point, and you had a lot of very good points in there. But I am a 79-year-old lady that I've had diabetes for quite some time. Although I've had it more controlled. Right now I'm sitting at a A1C of 6.2, I believe. But I've just started experiencing some discomfort in my feet. And it just started within the last week or so. My question to you is, even though I'm doing the best I can, do I still need to see a neurologist in order for him to prescribe some medication for this at this time?
I don't think you would necessarily need to see a neurologist. I think starting off with just a primary care doctor would probably be a best bet.
Okay.
You know, the typical symptoms of neuropathy would be numbness, tingling, burning sensation. Usually, if it's due to diabetes, it can start in the toes and then it works its way up more proximally. So it kind of starts in the toes, and then it goes to the entire foot, and then it can go up the leg. Sometimes it's referred to as like a stocking distribution. So it's like if you put socks on, it's kind of,
like a compression socks?
No, sorry. I think I'm confusing you. No, just in the terms of the distribution of the symptoms, it's referred to as like a stocking distribution. But the point I want to get at is that that those are generalized symptoms of neuropathy. Neuropathy just means nerve inflammation. Diabetes is one cause of neuropathy, but there are other causes. There's a vitamin deficiency, B12 deficiency that can cause a neuropathy. Sometimes there can be nerve impingements in the body that can cause a neuropathy. And they all can be treated just a little differently. With your sugars being so well controlled, an A1C of 6.2% is phenomenal. So congratulations on that point. You're doing an excellent job. When it's diabetic neuropathy due to diabetes, usually that's people that have had pretty poor control of the diabetes, either historically or currently. And so if your sugars are looking pretty good and the neuropathy is just now beginning, I think we might want to open up the differential to see if maybe there's other causes for the neuropathy or symptoms. And starting with the primary care doctor, I think would be a really good idea. They can do the initial exam as well as testing to make sure this is neuropathy. It's not some vascular issue going on. And then they can oftentimes offer some treatments to help mitigate some of the symptoms that you're experiencing.
Thank you, Dr. Goodwin. I appreciate that. And I will follow up with my primary care.
Sure.
Thank you, Dr. Goodwin. We have time for one more question. Patricia Thomas, please take yourself off mute and feel free to ask your question.
Hello, Dr. Goodwin.
Hi.
I have a question regarding dawn phenomenon.
Mhm.
I got diagnosed with diabetes in December of 2020, and my A1C at that time was 10. And I got it down to, actually the lowest that I've gotten it to was 4.8. And then it did go back up to what, 5.0, then 5.1, 5.7. Then it went back down to 5.1. Now it's at 5.4. But lately, my numbers when I wake up, my numbers be 140, 139, 131. But then a couple of times it was like 125. One time it was 117. So my question is, how do I control this dawn phenomenon if that's what I'm experiencing?
Sure. So with your A1Cs being in the lower fives, I mean, that would be an average sugar, probably 90s. And so if you're waking up in the morning, you're seeing sugars 130s, 140s, and your overall average is 90s, that would kind of imply that you're having lower sugars later on in the day. There is one thing that I would just want to make sure that we rule out before we call this dawn phenomenon. There is another phenomenon that's called the Somogyi effect. And it's
Right.
much more rare than the dawn phenomenon, but that is where when someone goes to bed at night, they have a hypoglycemic event, maybe they're not even aware of it, where their sugars drop too low. They drop, in the 50s or even lower. And because of that, their adrenal glands get activated. They make these stress hormones, these fight or flight hormones that surge in the body, and they tell the liver to start making more sugar to bring the blood sugar up. And so by the time someone wakes up in the morning, their blood sugar is high. And it's not necessarily because their sugar's trending up. It's because they had a low sugar in the middle of the night that maybe they weren't even aware of. And the treatment of that is actually reducing medicines down for the diabetes. We prevent the hypoglycemic, we prevent the low sugar from happening. So one way to rule that, I mean, there's a couple of ways we can do. One way would be to set an alarm and check your finger stick, like at 2 o'clock, 3 o'clock in the morning, to see where you're at. And if you're trending low at that time, 60s, lower, you may want to talk to your doctor about reducing medicines down. The other way would be if you are wearing a sensor, continuous glucose monitor. It's a separate device that records sugars. We can see if someone's having low sugars. If we rule out someone is not having hypoglycemia in the middle of the night, then what you are experiencing would be a dawn phenomenon, and that's where the body makes, the liver starts making sugar, not because of a stimulus from a low sugar, but it just starts producing sugar in the middle of the night. And the pancreas, because the diabetes isn't able to make enough insulin to help counteract that sugar. And sometimes that dawn phenomenon effect, again, if it's dawn phenomenon, it's not from a low sugar, it can be treated by doing a small snack at bedtime of a little bit of a carb plus some fat or protein. So usually like a cheese stick, or maybe like some apple slices and peanut butter. And what that can do is it can help to stimulate your pancreas to start producing just a little bit of insulin in the middle of the night when you're sleeping to help lower the blood sugar down in the morning. It kind of sounds counterintuitive to eat a snack to lower your sugar in the morning, but in a lot of people, it does help to control that dawn effect.
Okay, because I'm not on any medications for my diabetes. I've been treating it strictly by diet.
Oh, okay. Yeah. Yeah. I mean, I don't want to get too many details because I think this is like it's a recorded call, but I would still have a conversation with your doctor to kind of rule out hypoglycemia, and then still doing it, getting a little bit more calories in right before you go to bed may actually help to lower that down a little bit. The other thing too to look at, if you're not on any medicines and if you're not symptomatic from a sugar of 140, which I wouldn't expect you to be, and your overall average is fine, I probably wouldn't worry about it.
Okay, all right.
If your overall average is fine, you're not going to be at risk of developing complications. And if you're not symptomatic from the sugar 140, meaning you're not having blurry vision, peeing more frequently, feeling more thirsty, numbness, tingling in the toes, and later on in the day, the sugars have to come down because again, if your A1C is in the fives, it's going to be coming down naturally. I don't know if we would necessarily have to go after that too aggressively.
Okay, thank you.
Yeah.
Thank you very much, Dr. Goodwin. I did send you one more question in the chat. I'm not sure if you can stay and answer that question during the break. We do need to move into our next segment with Dr. Spicer, who unfortunately couldn't be here with us today, but we are going to share her podiatry talk with you all. So yes, if you can answer that either briefly or during the break, either one would be greatly appreciated.
I'll respond back in the chat.
Okay, thank you very much. Cheryl did ask the question. Thank you. Okay, give me 1 second. Let me pull up this talk for you all. Thank you very much. Again, Dr. Goodwin. Now we are going to move into our talk with Stephanie Spicer. And I will have Kim introduce her. Can everybody see my screen okay?
Yes.
Yes.
Thank you.
Okay, good morning, everyone. I'd like to introduce our next speaker, Dr. Stephanie Spicer. She's a podiatrist.
Can everybody hear the video okay?
I
No.
can. It's a little vague, but I can hear it.
It's not clear.
Foot and ankle evaluation, treatment, and surgery to patient and practice foot and ankle group in Olympic fields of Illinois. Serving the greater Chicagoland area, Dr. Spicer strives to educate her patients so that they can be involved in their treatment and make informed decisions. Dr. Spicer has maintained surgical board certification for over 20 years. She completed orthopedic and surgical residency programs at Hines, Loyola Hospitals, and St. Joseph Hospital in Chicago, Illinois. Her postgraduate training included, but not limited to, wound care, sports medicine, instructor, rear foot surgeries, and trauma, as well as foot and ankle problems related to systemic disease. Let's welcome Dr. Stephanie Spicer.
Thank you so much. Good morning, everyone. First of all, I just want to thank Ms. Ollie Smith for inviting me to this wonderful forum. I've known Ms. Ollie for years now, and I just absolutely admire her passion for all things diabetic as it relates to educating people and providing resources. So with that said, can we start our slide presentation? Dr. Spicer, were you gonna podiatry has become a huge adjunct profession. Currently, and part of it, I believe, is because of the increased number of diabetic patients. We actually provide services that are probably more specialized, and I feel like we are contributing to keeping diabetic patients healthy and active. Dr. Spicer, I'm not sure if I will. So Foot and Ankle Group is my practice. I'm physician owner of Foot and Ankle Group located in Olympia Fields, Illinois. Again, I am a board certified podiatric physician and surgeon. My practice actually houses two other doctors, Dr. Darla Thomas, who is our emerging diabetic foot care specialist, and Dr. Stephanie Oxman, who specializes in nerve pathology, trauma, and reconstructive surgery. Next slide. So diabetes obviously is the topic for discussion this weekend. Dr. Goodwin so eloquently shared with us what diabetes is and how it's caused on a cellular level. In summation, decreased production or response to insulin is what diabetes is. As it relates to the lower extremity, our concerns are that excess glucose affects blood vessels, nerves, and the immune system. Demographics, diabetes is no respecter of persons. It affects all ethnicities. It is actually global. And we do see that it's more prevalent in men and adults. Although I might add that the number of young people with diabetes is escalating exponentially. So what does this mean to the foot? It's obvious from this awareness conference that diabetes affects the body from head to toe. The things that concern us in podiatry are decreased blood flow, altered or loss of sensation in the feet, changes in skin integrity, atrophy of muscles in the foot, and all of these things create an increased risk of infection. Next slide, please. So what? The most egregious thing that we treat in podiatry, unfortunately, are diabetic foot ulcers. And they're caused by a myriad of things that diabetes escalates, although they do happen in non-diabetic patients as well. Again, change in the foot architecture and decreased skin integrity makes people more prone to ulcerations, and diabetics experience this more frequently. Lack of sensation, also known as neuropathy, is where a patient cannot appropriately feel pressure or pain. Pressure, pain are all red flags or sirens to us to let us know that our body is in distress. So when you cannot discern that, it makes one very vulnerable. Decreased blood flow. Blood flow is the blood itself is the life-giving fuel to all tissues and organs in our body. Whenever we have an area where blood flow is inadequate, then healing is, I won't say it's diminished, but it's certainly prolonged. And it can also lead to tissue death. Next slide, please. Also, diabetic patients have altered immunity often. That means they lack the ability to fight infection compared to a patient without diabetes. Infection is a big deal. It starts generally with something small in the skin or subcutaneous tissues. But unfortunately, what we see in many diabetic patients are bone infections, also known as osteomyelitis. We also see blood infections, also known as sepsis, where bacteria actually seeps into the bloodstream. Uncontrolled infection can absolutely lead to death. Podiatry, by and large, is a non-emergent medical specialty. However, in my practice, my most emergent issues, by and large, are those of diabetic ulcerations and foot infection. Next slide, please. So this is a depiction of an ulcer, or how we grade and stage various ulcers. First, let me define that an ulcer is an open sore or wound caused by a break in the skin that fails to heal. I have so many diabetic patients that I see with this issue. I have a gentleman that I saw in the hospital who had been out at the beach with his family, and he was in the water and in the sand with no shoes on. Subsequently, he left the beach, walked across the parking lot to get into his car to go home. And a couple days later, he realized he had ulcers or wounds on the bottom of his feet because he was insensate and did not feel that the asphalt / concrete that he was walking on was hot. So this gentleman presented with a grade 3 ulcer, which is the third from the right side, grade 3 abscess and osteotitis. This gentleman had a wound that had become deep and infected. And actually, in his case, it seeded to bone, so he ended up with osteomyelitis. He is a happy ending in that he went on to have IV antibiotic therapy. Unfortunately, he lost one of his toes, but he is walking, working, healthy and well in spite of that experience. So that's just an example of some of the things that we see with diabetic patients. Next slide. I know this picture isn't pretty, but I thought it was worth sharing. These are different types of ulcers, if you will, that we see in patients with diabetes. The first type we call vascular, also known as ischemic. And those ulcers occur due to lack of blood flow. They often present with a sweet smell, kind of crusty tissue that looks like a scab. In patients that are insensate, there's no pain. However, patients that do not have neuropathy experience significant pain with this type of ulceration. The second one is pressure ulcers, which we see all over the body, and they are a result of friction or rubbing against the skin redundantly, and it creates tissue death in those areas. Lastly, neuropathic. Again, that means inability to feel insult. So this is a prime example of a patient who walked around with a pebble in his shoe, and because they weren't able to feel it, could not discern pain, discomfort, something foreign, it became an ulceration. Next slide, please. So here's some sobering statistics about diabetic ulcers. Again, diabetes is worldwide. And so the annual incidence of diabetic foot ulcerations is up to 26.1 million. Approximately 15 to 25% of people with diabetes will go on to develop an ulcer in the foot during their lifetime. And in the United States, the majority of amputations that don't involve a traumatic incident are performed on with diabetes. In my hospital practice, where I actually go to take call on inpatients or ER patients, the sweeping majority of those people have diabetic foot ulcers and infection. And in my hospital practice, 85% of those patients go on to need some form of surgery versus my office practice, where patients come in for intermittent care, early intervention, monitoring, and resource provision. Those patients in my office are less than 20% as it relates to a surgical intervention. Next slide. So what can you do, the population at large, for diabetic foot care to prevent ulcerations or complications as it relates to diabetes in the feet? Of course, number one is control blood sugars. And we've heard from many speakers over the last 2 weekends, giving us information, advice, and resources on how to do that. Medication, diet control, preparation of food, etc. Obviously, I suggest seeing a podiatrist regularly, but things that can be done at home are inspecting both feet daily, and that is not a glance. That is actually taking the time to look at the feet between the toes, the tops, the soles, etc. I often advise my patients who have issues with movement or flexibility to use a mirror to help them visualize what's going on with their feet. It's important to always wear shoes. Shoes are the armor or protectors of the feet, even when at home. I see so many patients that place their feet in extreme temperatures, particularly those with neuropathy, because they can't feel the danger. People go to nail spas or on vacation in hot tubs and just enjoying themselves, not realizing that they're putting themselves in danger. Seeking treatment for injuries, discoloration, bruises, or cuts on the foot or feet is absolutely important and should be done as soon as possible. And any observation of redness, swelling, warmth, drainage, open wounds are urgent and require immediate care. Early detection and intervention saves limbs. Next slide, please. So I do have good news. Diabetic foot care is actually something that is covered by insurance. Palliative care prevents complications by monitoring foot health and managing minor issues that can become serious. I actually see diabetic patients on a daily basis, and each patient is an individual. Some patients need only annual evaluations because they're managing well, they're healthy, and they have no comorbidities as it relates to their feet. I have other patients that come in up to every 3 months because they're unable to manage or care for their feet properly. So it becomes my job to look at them, evaluate, provide resources for prevention. Another great thing that I wanted to share is that there are actually shoes made to help diabetic foot complications. Medicare and most commercial insurances cover 1 pair of therapeutic shoes and inserts each calendar year. That is so awesome. Next slide, please. So what are diabetic shoes? Honestly, they're just shoes, but they do have essential features that other shoes may not. In order for a shoe to qualify as a diabetic therapeutic shoe, it has a wide and deep toe box. It comes with supportive insoles or inserts for shock absorption and to mitigate friction and pressure. And actually, they come in a myriad of sizes and widths, which is not always readily available in our retail situation. Next slide, please. So diabetic shoes have come a long way. When I started practicing 20 years ago, they kind of scared me because they were so unattractive. But fortunately, we have progressed and they really rival any other shoe that you can see on the shelf in retail stores. Diabetic shoes now come in dress shoes, athletic shoes, leisure shoes, house shoes, hiking boots, steel-toed work boots, non-skid work shoes, et cetera, et cetera, et cetera. So the selection is attractive, as well as healthy and therapeutic. My dad actually was diabetic, and whenever a new cool looking shoe came on the market in my resource realm, I'd buy it, send it, and he'd notoriously wear his new shoes to the barbershop, where all the patrons there would just give him compliments and dap on his fabulous looking shoes. So there's a plug for therapeutic shoes. Next slide, please. So this is a saying, one of my favorites from Mahatma Gandhi, and it is health that is real wealth and not pieces of gold or silver. You know, physical change is inevitable for all of us. And I think that we should look at health as an action word. You must be involved and participate in order to remain healthy. It doesn't magically happen. And I think one of the singular messages of this conference is that we're imparting knowledge and hopefully resources for patients with diabetes, or who are here as advocates for family members or friends. And it's to empower taking that knowledge, creating self-care and self-advocacy. Next slide, please. That's my spiel. Thank you.
Thank you all very much. That was Dr. Spicer's presentation. She did offer that last year. Unfortunately, she had some issues that she is currently dealing with. So let's keep her in our prayers as well. If you do have any questions regarding her presentation, please put them into the chat and we will make sure that we get them answered from her. At this time, we are going to take, well, just anybody have anything that they'd like to share at this moment? Someone sharing? No? Okay.
Yes.
Well, we're going to take,
Yes.
go ahead.
I would like to say that I've been to many podiatrists and I thought that they all were excellent. It was not until I went to Dr. Spicer that I found out what an excellent podiatrist actually is. I'm having problems with neuropathy. She sent me for testing that has never happened, for arterial and venous testing. She let me a pair of diabetic shoes that people are looking at and saying, where did you buy those shoes? Oh, these are diabetic shoes. And these shoes have helped me to feel more steady on my feet because I was having balance issues due to the neuropathy, and the wind could blow and I could feel myself almost falling over. I have been steady on my feet. I have not had the pain that I have been experiencing. And she is a doctor that is very interactive with her patients and actually listens. I could not recommend her more highly. Everyone from the front desk to the MAs to the doctor herself, they just are very caring and very attentive to a patient's needs. So I couldn't recommend her more highly.
Thank you very much, Karen. We are going to take about a 5-minute break right now, and then we're going to move into our next two presentations. You will be hearing from our vision health specialist, Dr. Johnson, and then our kidney health specialist, Dr. Kennedy. So the 5-minute break, I'm going to play some music and we'll be right back. Okay. Thank you.
Welcome back, everyone. My name is Tara Allen. I'm one of the board members on Stonebridge, and I just wanted to welcome everybody back. Thanks so much for joining us today. I also want to thank our two speakers so far, Dr. Goodwin, Dr. Spicer. And now we're going to go right into our second half of the program. We are about to hear from Dr. Ansel Johnson. I wanted to just give a brief overview of who Dr. Johnson is. He's the founder and clinical director of Vision Salon Eye Care Associates in Blue Island, received his doctorate degree from the New England College of Optometry in Boston, completed a postgraduate certificate from the Optometry Executive Program at the Wharton School of Business. He's currently adjunct professor at 4 different Doctor of Optometry programs, serves on the staff at Advocate Trinity in Chicago. And this was a major accomplishment for his office. They're one of the first and only in the state of Illinois to incorporate a nationally certified diabetes self-management program within an eye care facility. He's a certified lifestyle coach for the CDC Diabetes Prevention Program, which has been proven to work. Member of the Association of Diabetes Care and Education Specialists for over 20 years. He focuses on diabetes eye care, new technologies, and glaucoma management. Just last year, or 2 years ago, 2020, June, Dr. Johnson founded and serves as CEO of the Health Living with a Vision Foundation. Their mission is to eliminate the health and wellness disparities in communities of color. Dr. Johnson has received various accolades, but twice he's been listed in Black Enterprise magazine as one of America's top 101 African-American doctors. He also was honored during a White House ceremony while Clinton was president as a Head Start success story. He's a proud member of Phi Beta Sigma fraternity, continually working in the community to positively impact eye care and health care. I'd like to welcome right now Dr. Ansel Johnson.
Well, thank you so very much for that introduction. I really appreciate the opportunity to present. I thank you for the invitation. It's truly a blessing to share a lot of information with the public, with people in general, and provide an opportunity for our patients to, in our community, to learn, one-on-one, two-on-one, or as many in this group as possible, because when we started Healthy Living with the Vision Foundation, we were finding that there is so much disparity in just knowledge. And sometimes people just don't know what to ask. So with that being said, we're going to get started on eye care, and I'm going to see if I can share my screen. Start the presentation. All right, can everyone see that screen?
Yes.
Yes.
Okay, great.
Yes.
All right, again, I want to thank Stonebridge, the Outreach Initiative, for inviting me today. And as mentioned, I am President and CEO of Healthy Living with a Vision Foundation. And I'm all about collaboration. So it's about sharing information and empowering our community, because sometimes we have these issues, diabetes, hypertension, other things, kidney dysfunction, foot problems that we feel powerless about. And I want to say that we can be very powerful and engaged in our healthcare. And again, some more about me, and I appreciate the introduction. I am an eye doctor and I'm an advocate for my community. As I talk to people in the community, of all communities, it's about us. And again, I was also featured in the newspaper, local newspaper, Southland Journal, about a few years ago about our diabetes program. And one of the biggest things when people fear about diabetes, it is a leading cause of blindness or impaired vision in adults in this country. And so that's a lot of people's major fear is loss of sight. And just like my predecessor, who's a podiatrist, only about 5% of doctors in the United States are African-American. And in terms of optometry, less than 2% of us are Black. So that's an opportunity, but it's also a marching orders for us to try to duplicate ourselves. And unfortunately, I think we're falling behind a little bit. But in my office, we have 3 optometrists. In the middle there, Dr. Shannon, myself, and Dr. Leonidas Johnson. And so it's a rare opportunity for us together to try to impact, our community and eye care in our community. And with that being said, we need your support. We need you to encourage your children to look into the STEM careers and the healthcare careers, because too soon we're going to wake up and say, why are there no Black doctors? Or many of us have gone through life without ever seeing a doctor that reflects us. So we're out here, not many of us, but please seek us out and support us. And also going on here, we're going to start in terms of, we're going to talk about diabetic eye care, but also some of the things that we see more commonly when we're living with diabetes. And let's start with this little video, basically, how do I see it? It kind of gives a summation about how the eyes work overall. And this is about 1.5 minutes. So just stay tuned. And hopefully everybody will be able to see if my technology works.
How do we see? Let's follow the light. Light enters the cornea, the clear window of the eye. The cornea bends the light, so it passes through the pupil. The iris makes the pupil bigger or smaller. How do we see? Let's follow the light. Light enters the cornea, the clear window of the eye. The cornea bends the light, so it passes through the pupil. The iris makes the pupil bigger or smaller, which determines how much light gets to the lens. The lens angles the light through the clear vitreous to focus it on the retina. The retina converts the light into electrical impulses. These impulses travel along the optic nerve to your brain, producing an image. While it may sound complicated, this happens in less than a second and allows you to see the world around you.
Okay, great. Just a short video, kind of an overview, because a lot of times people think about the eyes just being a solid organ, and there are many different parts. A lot of the times we get mixed up specifically between glaucoma and cataracts. Those are 2 eye problems that most people hear a lot about. And so I'm going to get into a little bit about the differences in all of those. And then we see, again, these problems much more commonly in people living with diabetes. And then I also want to address when you are living with diabetes does not define you. So I always like to use the term living with diabetes. It's one of these things that you can live with, manage, and partner with your healthcare provider to still live your best life. It's not a sentence to being blind or having kidney dialysis and things of that nature. So I'm gonna again give you some more information in terms of living your best life. And we all have heard about the healthcare disparities, and I'm sure you've heard a little bit about this in some of your previous presentations. But compared with white adults, the risk of having diabetes diagnosis is 77% higher among African Americans. And there's a reason for that. And we have a lower rate of receiving eye care in terms of annual diabetic eye exams. And then there are disparities of outcomes, meaning that, yeah, we lose sight more, or when we do finally go in, it's much more advanced. And so that it's a lot of this is attributed to the type of care that we receive. And in the previous slide, I talked a little bit about how the small number of African-American doctors, but there are plenty of studies that show that African-American people do better with African-American doctors. And so there's a sensitivity to when we see our own patients to be able to relate, to be able to communicate. And so that's very important. That is not disputed by any journal or anything like that. It's been in the journal of the American Journal of Optometry, the New England Journal of Medicine. This is, and there's a reason for that. Again, because there's certain sensitivities. We know that in terms of women that have died in childbirth is much higher in African Americans. Serena Williams, her story is very well known in terms of the outcomes that she has had. So one message that I want to say is that preventative care, don't wait until you can't see, until vision is blurred. Sometimes we wait till the wheels fall off the wagon. Now, one of the reasons that people come to their eye doctor is that are discovered as diabetic is blurred vision. So we see a number of patients that come into our office, no other symptoms, they just know their vision is blurry. And then we check, okay, have you been real thirsty lately, drinking a lot of fluid? Have you been real tired? Have you been going to the bathroom a lot? In many, many cases, the initial suspicion of diabetes is when patients go to the eye doctor. There are even cases where I will see someone and they may even have told me that they were borderline for diabetes. And that basically means that your blood sugar is fluctuating up and down. Now, we are really on people that say that they're borderline and have been told that they're borderline for diabetes, because you really have to change your mindset and start thinking as if you are living with diabetes. And my own personal testimony is that I am a doctor that is living with type 2 diabetes. And I was a knucklehead. So I was told I was pre-diabetic for many, many years. Okay, and I had the fit-into syndrome. And if anybody knows what the fit-into syndrome is, it's like, oh, I'm fitting to eat better. I'm fitting to lose weight. I'm fitting to act right. I'm fitting to exercise. All of those lifestyle changes I'm fitting to do until there's a catastrophic or almost catastrophic healthcare incident that God taps you on the shoulder and says, you better get it together, brother. So, and that's what literally happened to me. So I share with my patients, I walk that same walk. My patients living with diabetes or with borderline or pre-diabetes every day. Those decisions that you make, I need to get a little workout in, I need to exercise, I need to walk, I need to be more active, I need to take my medications. All of these things, I need to make better judgments. I need to food prep. It's a lot and overwhelming for a lot of people. But what we do, we help people, especially with our diabetes education program and in our Healthy Living with a Vision Foundation, give people step-by-step, small steps that they can make to move in the proper direction in their lifestyle. And there are going to be times you're going to fall back a little bit, but as long as your trajectory overall is for the better. Now, glaucoma is a eye ailment, potentially blinding eye disease that we see more often in people who are living with diabetes. And it is a progressive disease in which the back of the eye, the back wall of the eye, there's a nerve that connects the eye to the brain. And that's why I like to show that initial video, the connection between the eye and the brain. That nerve connection degenerates slowly over a number of years. So what happens with glaucoma, you lose your peripheral vision first. So the clear vision straight ahead is the very last to go. So there are many, many people walking around with glaucoma that are slowly losing their side vision. And by the time they get into the eye doctor, because they notice things to the side are sneaking up on them, or they're sideswiping the cars, or they're just, they just know something's not right. And then we've already seen a progressive or a huge loss of their side or peripheral vision, but side vision up and down, and that can be more progressed in one eye. So if you have a blind spot that's developing and getting larger in one eye, you may not notice it because that same blind spot is not seen in the other eye, because the two eyes, the whole world that you see, the side vision overlaps. So glaucoma is one huge reason I'm a big advocate on annual eye exams for all adults. It doesn't mean your glasses is going to change every year, but you need to see a provider that can manage both the medical part as well as the vision part of the eye. And sometimes that's a little hard to find. The glaucoma, the video talked about a vitreous or a fluid or jelly-like substance inside the eye. That has a pressure that we can measure, just like measuring the air in a tire. And so when they screen you and see the pressures elevated, one of the first things in our mind is that, okay, we have to really look into this a little bit more and see if you have glaucoma. The other part of that is that we know that there are a lot of people that have glaucoma that may not have high eye pressures. A lot of people with glaucoma have what we may call normal eye pressure. So that's not the only thing you have to go by. And so again, it's one of those things where if there is permanent vision loss, the vision loss is permanent. You can't get it back. So if you have lost a lot of your side vision, you can't get it back. So how is that related to diabetes? Well, we know the circulation around the nerve in the back of the eye puts it more at risk for glaucoma too. And diabetes definitely affects the blood flow throughout the eyes and the rest of the body. Another symptom we often see with people living with diabetes is dry eye, because diabetes is an inflammatory disease where basically the blood vessels become more porous, you get leaking fluid, you have the sugar level within the blood flow throws off the balance, what we call osmotic balance. In other words, how the fluid flows out of the blood vessels and into the blood vessels. And you get what we call inflammation. And inflammation affects the delicate tears, the delicate tissues around the eyeball, and can cause dry eye. So you're not secreting enough fluid to keep the eyes moist. So other causes of dry eye are allergies, medications. If you're on hypertensive medications, a lot of that cause you to urinate more, you get dry eye. Dry eye can result from normal aging changes and also the environment. But again, we're focusing on diabetes. So there's a whole myriad of things that we look at. And one thing I want to share with everybody, a lot of times we as doctors fall short because we just tell patients, go pick up some eye drops or lubricating drops on the shelves in the drugstores. And one big mistake a lot of people get, they get like Visine or Clear Eyes, and those are some of the worst things you can do to treat dry eyes. And so you really need more guidance from your eye doctor. One quick tip is if you're gonna use eye drops for lubrication, try to find drops that are preservative-free. Preservative-free eye drops you can't overdose on. You can use them as much as you want or as little as you want, but it's not gonna harm your eye if you use them a lot. And this is, again, a little illustration in terms of the delicate tissues around the eyelids here that produce the moisture inside the eyes. And again, these get inflamed. And then it reduces the amount of tears that help lubricate and wash the eyes. Cataracts, we see a lot. Cataracts is a clouding of the lens inside a person's eye. And that's towards the front part of the eye, where you have a little camera lens, and that gets cloudy and hazy over time. And cataracts is analogous to getting gray hair, more gray hairs. That lens doesn't stay crystal clear all of our lives, but it can slowly get cloudy. One huge way in which cataracts worsen it, again, is diabetes, because blood sugar is fluctuating up and down. That causes that lens to get cloudier more quickly. And so sometimes that cataract will develop to the point where surgery is needed more quickly in patients living with diabetes. There's certain medications that enhance the formation of cataracts, and just being out in an environment without good quality sunglasses and light exposure can enhance the formation of cataracts, or that clouding in the back of the eyes. And this again is another illustration where cataracts are. It's a lens, the cloudiness of the lens in back of the eyes. And this is an illustration in terms of how light coming to the eye, how it's scattered, cloudy, hazy, and that can happen more quickly. So that's cataracts, again, towards the front of the eyes. Now, how can we help some of these issues? As I said, diabetes is an inflammatory condition. So a lot of times I will recommend that patients take a good quality fish oil supplement or flaxseed oil. It's anti-inflammatory. I prescribe it a lot of times over the counter. That can help dry eyes and help decrease inflammation in diabetes, and also can support people with autoimmune diseases like lupus, sarcoidosis, and things of that nature. So it's a natural thing. Now, the key with fish oil supplements, again, you go to the store, you'll see a whole bunch of fish oil supplements. And what I teach my patients is what to look at on the labels in terms of a good quality fish oil supplement. And unfortunately, most of those that you find commonly in the drugstores are not very well absorbed. And again, a good source of natural source out of your diet is good cold water fish, like cod, salmon, mackerel, whitefish. And you want these wildly caught instead of farm raised. Flaxseed oil, there's huge movement and shown the benefits towards a more plant-based diet is much more healthy for those of us living with diabetes. So good flaxseed oil is also a great source for fish oil, omega-3 fatty acid, and it can also help with in terms of reducing your cholesterol. And again, living life with your best vision, inflammatory eye conditions, again, dry eyes, diabetic retinopathy. Diabetic retinopathy is the #1 culprit for permanent and extended vision loss, because that's where you get bleeding, swelling, and scarring in the back of the eyes. And that's what we don't want the eyes to get to. Iritis, which is painful, light sensitivity, and eye pain in general. Now, cardiovascular conditions, again, type 2 diabetes, huge hypertension, atherosclerosis, high levels of cholesterol, and having a history of stroke or heart attack. When people, and I always talk about, when I talk about eye conditions, I talk about the physical conditions, because when I look inside the eye and I look at the blood vessels in the back of a person's eyes, I pretty much have a fairly decent idea on how their cardiovascular system is working. And again, these are other sources for fish oil supplements, natural sources. I'm not going to get into these a lot, but I will definitely share these sources if anybody wants after the presentation. And a lot of times people ask, what's a good eye vitamin? And there are actually vitamin supplements that I will recommend that people take that are evidence-based. In other words, it's shown that can be helpful in people living with diabetes to reduce or slow down early changes from diabetes. The carotenoids, people have heard a lot of times, well, eat your carrots. Carrots are good for the eyes. Not just carrots, there are other better sources. Green leafy vegetables, greens, collards, bell peppers of different colors, kale. Those are brightly colored squashes, brightly colored vegetables have these carotenoids that are very helpful for the eyes. They improve contrast sensitivity. They can actually help with vision, your color vision. Some people may have a deficit at night. Taking these supplements can also improve night vision in some people, and they can slow down cataract formation. And again, zeaxanthin, lutein, those are not buzzwords, but those are the two macular pigments that people need to look at on the labels of different products. And again, natural sources, egg yolk, zucchini, bell peppers, as I mentioned, olives, tomato juice, green peppers, cayenne pepper, peach parsley, spinach, pistachios, corn. So again, those are examples of just natural supplements for these things that are healthy for your eyes. And I love this slide because it shows different areas of the eye that that these different vitamin supplements can help. The cornea, vitamin C, that lens, lutein, zeaxanthin, vitamin C, the clear fluid inside the eye, vitamin C, the back of the eye macula, lutein and zeaxanthin, and also the retina, the back wall of the eyeball. Fish oil supplements, omega-3 fatty acids, beta carotene. Be careful about beta carotene though. It can have a detrimental effect on some people, but vitamin C and vitamin E. And again, these are food illustrations. I'm going to fly through these just to the time. And then healthy lifestyle. Healthy lifestyle will help people maintain good vision throughout their life. Things that are glaucoma friendly. Do not smoke. I am still amazed at people that are living with diabetes and high blood pressure that smoke. But on the other side of that, I understand smoking is very addictive, and that's not an accident. And so it's not simple for people that have lived their lives 20, 30 years a smoker. It's very difficult to stop cold turkey. But I try to emphasize that if you move more in that direction, the faster you can, the better. It takes about 3 years for the body to kind of somewhat normalize once you stop smoking. Maintaining a healthy weight. Our country is in an obesity epidemic right now. So we really need to be conscious about, we've heard about fat shaming, things of that nature. It's more about your health, more about your health. So we really need to move more towards healthy weight and movement. So maintaining normal blood pressure, movement, keep up with your visits to your eye doctor, to your primary care physician, and follow their prescribed treatment plans. But again, their lifestyle is huge. And that starts with our children. We need to push our children to be more active. That's a whole nother presentation. So considering starting an action plan, an exercise plan, only with your doctor's permission. So this dude is kind of getting to a good start, but that's better than nothing. At least he's moving, right? And then you have to have a plan. And so a lot of times with our patients, we help integrate SMART goals, which is specific, measurable, attainable, realistic, and timely. That keeps you out of the fitting to syndrome. Well, I'm fitting to lose weight. Next week, I'm going to do this. You have to have specific times. What are your goals? And a lot of times we tell patients, can you lose 1 pound a week? And most people are like, that's realistic. And also set a time limit. So all aspects of your life, especially your health, you want SMART goals. And why is it important to take care of yourself? Well, family's kind of huge. Your children, grandchildren, there are people that love you. And so they care about you. So sometimes, and I was a part of it, I kind of let myself go and, didn't care, but there's a whole lot of people that depend upon what I do. So family is huge, and the relationships you have with other people is an important reason to take care of yourself. So the title to our office is our theme verses where there's no vision, the people perish, which is Proverbs 29:19. And so your vision for your life, your outcome shouldn't be without limits. A lot of people, I hear my seniors talking about, well, I'm too old for this. I said, no, you're not. You have no idea what God has in store for you. So continue to live your best life and bless not only yourself, but the people around you with your presence. So I want to thank you for this opportunity to share a few little things. And as I always say, be well, see well, be blessed. And if there are any questions, I can be more than happy to entertain them.
Thank you, Dr. Johnson, for such a wonderful presentation. If you all have questions, please go ahead and ask Dr. Johnson right now.
I do have one question, Dr. Johnson. I
Sure.
spent a lot of time on a computer.
Mm-hmm.
So I think you said something in a previous presentation about the amount of time that you should look away from the computer and for how long to give your eyes a rest.
Okay. I have a real simple patented remedy for that, and it's Dr. J's 20/20 rule. So every 20 minutes, you want to get up and take 20 steps. So 10 steps away, 10 steps back to the computer. That does a couple of things. When you step up away, you're looking away from the computer and you're blinking a little bit more. So what happens when we're on a computer, our blink rate slows down. So in other words, because we're staring at the computer, you get more evaporation of fluid from the eyes. Even with our children who are on their cell phones a lot, we're seeing more dry eyes in kids because they're on their cell phone so much, causing the tissue damage because they're staring at the computer. So what that forces you to do when you get up and step away, you're going to get up and you're going to start blinking more naturally. And you're also moving. The computer, sitting at your computer for hours is the new smoking. They're finding it's detrimental to your overall health of smoking because you're not circulating, you're losing muscle tone. It's a real simple thing. Just get up, you're walking 10 steps away, 10 steps back. Takes less than 30 seconds and you're getting 60 steps a minute, 60 steps an hour in that you might not be getting in otherwise. So again, it's about movement, and so that will help. The other thing, the big concern about people talk about with computers is blue light. Now it's controversial whether blue light causes physical damage to the eyes, but one thing that we do know is that blue light will throw off your sleep cycle. And this is something I'm fighting myself because sometimes I'm working late, but then it's 10 o'clock, then it's 11 o'clock, then it's 12 o'clock. When you look up at the time, where did the time go? Because that blue light from the computer screen disturbs your sleep cycle. Same thing with our kids. And kids should be made to get off their computer, get off their phone 2 hours before bedtime. There are also, you can supplement the tears with, again, preservative-free artificial tears. There's a spray that I recommend. It's real easy to apply to help moisturize the eyes. And then there's a whole battery of treatments we have. So hopefully that helped.
Oh, yes, for sure. And I want to say, I'm actually one of your patients. I've been a long time patient of yours. But in 2011, I was having eye
Who
pain.
this?
This is Karen Evans, Karen Maria Evans.
Hey, Karen. Hey,
In
Karen.
2011, I had eye pain. I didn't know why. I thought it was the chemicals I was smelling from my cousin using a Glade automatic sprayer at her home. And you said something is wrong. It's not just that's aggravating your eyesight. You sent me to a retinal specialist. And when I went to him, he said, it's a good thing that you went to Dr. Johnson, because usually when I see people with this condition, it's too late to save their eyesight. I cannot thank you enough.
Oh, you are very welcome. And our battle all the time, and I'm glad you had a good outcome, because our battle all the time is to help before people get to that point. And one of the things that we'd love to collaborate more with Stonebridge, our foundation, we're having actually church panels. We have 2 other physicians on our board, and we're talking about various aspects of healthcare, diabetes and other things, just like what's happening here. And it takes a village to really raise awareness in our community so we can take control of our health. And so
Thank you so much, Dr. Johnson. And thanks if anyone else has any questions, please put them in the chat and we will make sure we get those questions to Dr. Johnson. All right. So now we are going to
thank you for those kind words.
All right. Thanks, Dr. Johnson. Now we are going to cover another hot topic,
You're very welcome.
All right. We're going to cover another topic. We're going to have Dr. April Kennedy. She is going to talk to us about the kidneys and diabetes. And so I just want to give a little bit of her background information. Dr. Kennedy received her medical degree at the University of Chicago Pritzker School of Medicine, went on to train in internal medicine and nephrology at the University of Illinois at Chicago. Since 2009, she's been working with associates in nephrology, born and raised southern suburbs of Chicago. She was happy to return home to practice at Advocate South Suburban Hospital and Franciscan St. James in Olympia Fields. She's a board certified nephrologist, equipped to care for the needs regarding diseases of the kidney, hypertension, and electrolyte imbalances. She currently lives with her husband, 2 kids, and has 2 puppies in Chicago. And in her free time, she enjoys cooking, shopping, traveling, and walks. Dr. Kennedy, I am going to share my screen and pull up your slides. Just give me a moment.
Okay. Thank you for that introduction. Can everybody hear me okay?
Yes.
Yes.
All right.
Okay, Dr. Kennedy, you're all set.
All right, thank you. So thank you for that introduction, and thank you for having me come to speak today. Education about health is near and dear to my heart. You know, I feel that if we know better, when we know better, we can absolutely do better. I've never met a person or a patient who didn't want to live a long and healthy life. So I just think it's so important to have forums like this where we can get the information that we need. A couple things I just want to say at the start. I was just looking at the names and I didn't notice a lot of names of gentlemen. I think I saw mostly ladies' names. And a lot of times when I go and do talks, there's a good amount of women, not so many men. So, you know, ladies, it's just another job that we have to take this information back to the men in our lives, the men in our families, to make sure that they're taking good care of themselves as well. And I'm going to start with just a statistic just to make you guys aware that African Americans are 4 times more likely to suffer from kidney failure than our other raced counterparts in this country. So I'm going to talk to you really about the kidney. I will, touch on diabetes and hypertension as well, but this is really some information about the kidney. Next slide. So of course, I think the kidney is amazing. I'm a little bit biased. But most of us have 2 kidneys. They're bean-shaped organs that are located in your abdomen, and each kidney is about the size of your fist. About 10 to 11 centimeters is the average size. Again, most people have 2 kidneys. You can live a long, healthy life with 1 kidney. And in fact, when kidney transplants are done, most adults receive 1 kidney, and that does good for the remainder of their life. Next slide. You're gonna have to click a couple times. I got some animation. All right, so how the kidney works. So each kidney has millions of tiny filtering units called nephrons. These nephrons contain hundreds of miles of tubes and filters, and these tubes and filters process your blood as it passes through. Waste and excess fluid is removed from your body as urine. And then anything that your body wants to keep in, it reabsorbs and takes it back to the heart to pump out into the system. Next slide. So again, the kidney is amazing. These 2 organs filter about 40 gallons of blood every 24 hours, and they never take a rest. Even when you're sleeping, they are working hard. That means your entire blood supply is circulating through your kidneys about every 2 minutes. So it's important that you take care of them. Next slide. So one of the main functions of the kidney is that they remove waste products. Any things that we consume make metabolic waste. And as I had mentioned, your body decides what things to keep and what things to throw away. So there are some substances that your kidneys directly work to remove, and they include urea, creatinine, sodium, potassium, phosphorus. Some drugs or medications are filtered through the kidney, and then other waste products. So I want you to just keep these words in the back of your mind as we talk about how you can assess kidney function. You're going to see them come up again. Your kidneys regulate volume. Of course, that makes sense. Your kidneys make urine, so the fact that they regulate the water in your body is not at all surprising. Volume, though, plays a very important part in the function of your kidneys and your heart. And I always explain to patients that you have to think of sodium as volume, or think of sodium as water. Wherever sodium goes, water goes. So your kidneys are regulating the salt and the sodium, which is coupled really closely to the fluid in your body. Next slide. Speaking of salt and water, healthy kidneys help regulate your blood pressure. They do this by balancing the amount of fluids and also releasing the hormone renin. So I often explain blood pressure with that volume portion, kind of like a water hose analogy. You cut on the hose, you give the hose more pressure, that's gonna tighten the hose and increase that pressure when you make the water go through go faster through the hose, excuse me. So salt does that. Salt expands the amount of fluid in your body and expands that volume that's in your hose, which is your blood vessels. And this is something that drives high blood pressure. That's part of the reason why it's so important that we have to monitor and limit the salt in our body, because it's a direct driver of that water and of that pressure to your blood vessels. And as we all know, high blood pressure does not do anyone any good. Next slide. So this is the most current classification of hypertension. As you can see, normal blood pressure, less than 120 over 80. So 120 is the top number, that's systolic. 80 is the bottom number, that's diastolic. We begin to call blood pressure elevated once we see that someone's ranging 120 to 129 over less than 80. And then there's two stages of hypertension. Stage 1, 130 to 139 over 80 to 89. And then stage 2, at least 140 over 90. So early identification and intervention of high blood pressure is key, especially for African Americans, because we are at higher risk for cardiovascular events such as stroke, kidney failure, and sudden cardiac death. And when you're speaking of diabetes, we actually want our diabetic patients to have even more tight control of their blood pressure. So the goal for blood pressure in diabetics is always less than 135 over 80. Next slide. So there are non-pharmacologic or non-medicinal ways that you can help reduce your blood pressure, and they really work. I am in full support of medications, but our goal is to get the blood pressure down before any end organ damage occurs. So however we have to do it, whatever ways we want to institute, I think are fair game. So some things that you can do, lifestyle modification recommendations that can decrease your blood pressure, weight reduction, maintaining a normal BMI can decrease your blood pressure on average 5 to 20 millimeters of mercury. And there's kind of a rule of thumb, if you lose 10% of your body weight, that should help reduce your blood pressure by that 5 to 20 millimeters. The DASH eating plan. So this is a scientifically studied and scientifically approved diet. It stands for a dietary approach to solving hypertension. It's a diet that's rich in fruits and vegetables and low-fat dairy products with reduced saturated and total fat. And that diet alone can decrease your blood pressure by 8 to 14 millimeters of mercury. Sodium reduction. I can't stress that enough. Everything that we consume has salt in it. Most of the products in the United States have salt in it, mostly excessive, and we have to count that salt and take that salt into consideration. Reducing dietary sodium can decrease your blood pressure by 2 to 8 millimeters of mercury. Aerobic physical activity, another very, very important thing. Regular aerobic activity, at least 30 minutes a day, most of the days of the week. That's the goal that we should all have, and that can decrease your blood pressure by 4 to 9 millimeters of mercury. And then other things that you can do, moderate consumption of alcohol, obviously avoiding tobacco, all of those can improve your blood pressure. Next slide. So in addition to those few things that I had mentioned, kidneys also help keep your body in pH balance. They help keep your bones healthy, and they help you make red blood cells. And all three of these are usually are hormonally mediated mechanisms that I won't get into, but the kidney plays a very important part in those three functions as well. So what is kidney disease? Very simply put, kidney disease is when your kidneys are just no longer functioning properly. It's a serious disease that can lead to heart and blood vessel problems. If left untreated, it can lead to kidney failure, and kidney failure can eventually lead to end of life. But prevention and early detection is key, and there are things that we can do to halt progression and to avoid developing any kidney disease. Next slide. All right, so kidney disease is not absolute. I guess it's not either you have it or you don't. there's a continuum, there's stages, right? So we have broken kidney disease down into 5 stages, and I have them listed in this slide. And this is something important to know if you have kidney disease, if you have diabetes, if you have high blood pressure. It's important to know where you might fall amongst these stages. So there are 5 stages. There's stage 1. That's really if your kidney function is essentially normal, you might have some slight kidney damage, but we haven't seen that your body isn't able to filter your blood properly. And at that point, your kidney function percent should be more than 90. Stage 2 is when what we call a mild decrease in kidney function, and your kidneys are functioning between 60 to 89%. Stage 3 has recently been broken down in 3A and 3B. I'm just going to group them together. That's considered moderate decrease in the kidney function, and it's when your kidney function percent ranges anywhere between 30 to 59%. Stage 4 is considered severe decrease in kidney function, and that is 15 to 29%. And then stage 5 is kidney failure. That is when the kidneys are functioning at less than 15%. And this is also when we begin to institute dialysis. So one thing to know about kidney disease is that it often doesn't have any hard and fast symptoms. In fact, about 60% of people are walking around in the country today and they are unaware that they have any form of chronic kidney disease because they feel pretty fine. So it's very important to see your physician, see a kidney physician, your primary care physician, and have your numbers checked. And I'm gonna go through later on, what those numbers are, and also to know where you fall within these 5 stages. So a little word about these stages of kidney function. So estimated glomerular filtration rate, that's a fancy way of saying how well your kidneys are functioning, or the percent kidney function that you have. And I had gone through those in those, the 5 stages that we just went through in the previous slide. Historically, the studies that had identified people with kidney disease when they were done, African Americans had higher creatinine levels. And the creatinine is the blood test that we look at to determine what stage of kidney disease you have. And for decades, it was felt for a myriad of reasons that it was okay for African Americans to have a higher creatinine level, and that it didn't really mean too much different as far as our kidney function. But what was found as of late is that that is not the case. There was really no scientific evidence as to why someone had decided to say that African Americans were okay at higher levels of creatinine. And the National Kidney Foundation and the American Society of Nephrology recognized that finally, and they took away the adoption of a race-based approach to estimating kidney disease. So when you're looking at your kidney function labs, when you're talking to your doctor, make sure that they are not clicking the box and calling you African American when they're calculating your kidney function percent. Everyone's kidney function percent should be calculated on the same basis. And this is a very important step in healthcare equity, because what it does is it's allowing us to identify African Americans in earlier stages of kidney disease so that we can intervene. Next slide. All right. Are you at risk? Well, this is a diabetes education seminar. And the reason why kidney disease is on the panel is because diabetes is the most common cause of kidney disease in the United States of America. People are always saying there's so many dialysis units that are popping up in our communities. I see them on every corner. Unfortunately, that is a bit of the case. And one of the diseases that's driving that is diabetes, which is uncontrolled. So again, very important to make sure your diabetes is under control. The second most common cause of kidney failure is high blood pressure. Another disease, unfortunately, that is very rampant in minority communities, including the African American community. Smoking, obesity, any family history of kidney disease, diabetes, or high blood pressure puts you at risk. And then if you are African American, Native American, Asian American, Latinx, this is also increases your risk, and age greater than 60 increases your risk. So if you fall into any of these categories, it's just very, very important that you get your kidney function checked and are aware of your numbers. So what can you do? You want to take responsibility for your health. I can't stress this. I can't stress this more. Understand what's going on. Don't be afraid to ask questions. Ask the question until you understand. Your healthcare provider should be your partner in taking care of you, and find someone that you feel that you can have that relationship with. Know your numbers. So this is important. These are the things that physicians and kidney doctors are checking so that we know how your kidney is functioning. There's a urine test called the albumin to creatinine ratio. This urine test checks how much protein is in the urine. You should not have protein in your urine. Protein is a good thing, and your kidney should always reabsorb it and put it back into your bloodstream. When a kidney is not working properly, it will let that protein leach out into the urine, and then we're able to see it and we can measure it. So you want to know the albumin to creatinine ratio. This is a simple urine test. Your GFR, that's that kidney function percent that I was just speaking of. That is how we assess what stage of chronic kidney disease you are. That GFR is calculated using the creatinine, which is in your basic metabolic panel. That's a panel that you should at least have drawn once every year through your healthcare provider. And if you have any other illnesses, that might actually need to be checked more frequently. Know your blood pressure. I just went through what was normal blood pressure. 120/80 or better is optimal. If your blood pressure is higher than 140/90, you absolutely have high blood pressure. If you're anywhere in between, you're pre-hypertensive and you need to be aware, adjust your diet, increase your exercise, and even possibly start thinking about medications. Your hemoglobin A1C. So again, this is how we're assessing how well your diabetes is controlled. We want your hemoglobin A1C to be as low as possible, because that's the way that you convince your kidneys that it is not living in a diabetic environment. So if you have diabetes, this hemoglobin A1C should be checked around every 3 months. And it's very important to make sure that it's absolutely 7 or less, and if not 6 or less. Your cholesterol level, that's another simple blood test that just lets you know how much bad levels of fatty substances you have in your blood. Of course, if your cholesterol is high, this increases your risk of cardiovascular problems. So that is why that is an important number to know. And remember, there's no signs of kidney disease often until it's advanced. So you have to advocate for yourself and make sure that all of these things are being checked and that you understand these values. Protect your kidneys. So what can you do to protect your kidneys and avoid possibly ever having to see someone like me or being sent to a kidney specialist? Again, I can't stress controlling diabetes and controlling high blood pressure. Those are going to be number 1 and number 2 because of those are the number 1 and number 2 reasons why someone or anyone ends up on dialysis in the United States. Adopting a healthy lifestyle overall, a diet that's low in salt and fat, exercising regularly, maintaining a healthy weight, don't smoke. Those are the big 4 things that we can all do to protect our kidneys on a daily basis. Avoiding medications and substances that can negatively affect your kidney. So there's a class of drug that's very popularly used called nonsteroidals. Those include medicines like Advil, Aleve, ibuprofen, Motrin, naproxen, Celebrex. These are the medicines that we're using for our arthritis, for our headaches, for our muscle aches. But we know for a fact that these medicines can damage kidneys, especially if they're used excessively and over long periods of time. So we want to avoid these medicines if at all possible. I often suggest, for pain and things of that nature, to try Tylenol first and really save those nonsteroidals to if it's just the absolute last thing that you need. Also, ask your doctor before taking any herbal supplements or preparations. There have been supplements in the past that have actually caused damage. Now, many things have been regulated by the FDA, but a lot of supplements are not heavily regulated by the FDA. So in particular, if you're someone who has kidney disease, you want to make sure that the supplements aren't going to actually, cause you more harm than good. So check with your physician or your kidney specialist before you start taking any herbal supplements or preparations to make sure that they're going to be safe for you. So in the past, we didn't really have any great treatment options for kidney disease. We know that it's a progressive disease. As time goes on, it would get worse. And then eventually, you know, it could lead to requiring dialysis or renal replacement therapies. In the past couple of years, a new class of medications have come on the scene that have shown tremendous effects on stabilizing kidney dysfunction. So what that means is that if you have somebody who already has chronic kidney disease, there is some damage that has already been done. These medications have been proven to decrease the likelihood of that kidney damage getting worse and decrease the likelihood of someone eventually going into complete kidney failure. These medicines are the sodium glucose cotransporter 2 inhibitors. They're actually medications that were initially made for diabetes, made to control your blood sugar. And they do that, but more amazingly, they have these great effects on the kidney and also on your cardiovascular health. So we're now really urging patients with kidney disease and patients that have any type of congestive heart failure to get on these medications if they're a candidate. I have the 3 listed here, empagliflozin, canagliflozin, dapagliflozin, and their brand names. The only caveat is that your kidneys must be functioning at 25% or greater in order to use these medications. So if you're someone that's living with kidney disease, you're being followed by a physician, ask if you're eligible for one of these medications. All right, so the mainstay of treatment for kidney failure is kidney transplant. And I put this in there because it's just so important for us to be open to kidney transplant, okay, on the receiving and the giving end. It's the only cure for end-stage renal disease. It's the only way that we can get someone off of dialysis. And it's essentially a surgery that's done to replace a diseased kidney with a healthy kidney from a donor. That donor can be living or passed away. And just to show you the impact that transplantation has on the kidney community, a patient will live 10 to 15 years longer if they have had a kidney transplant. So it's very important that we urge people to list and urge people if they're eligible to donate. In Illinois, the average wait for a kidney is about 5 to 7 years. And with African Americans, sometimes that can be a little bit higher because of some of the proteins in our blood. But again, I can't stress how important considering kidney transplantation is. So the places in Illinois where you can go list for a kidney transplant are listed there. I won't read them to you, but if you are interested, if you are a kidney disease patient, I would look into either any of these facilities of your choice to be evaluated for kidney transplant if your physician says that you are at that stage. All right, of course, another obvious treatment option for kidney disease is dialysis. No one likes to talk about dialysis, which I completely understand, but I have to put it in here because I don't believe the community should be afraid of dialysis either. Dialysis saves people's lives, it extends people's lives, and it's a bridge until you can get that kidney transplant, which again, I had mentioned takes 5 to 7 years to wait for. So there's 2 different types of dialysis. There's hemodialysis, and that's the one that most are familiar with. Those are the dialysis units that you might see popping up in the community. And then there's peritoneal dialysis. And this is a type of dialysis that's only done at home. And I'll talk a bit about that in next slides. But there are 88% of patients worldwide on dialysis are receiving hemodialysis. So again, that's the most common one worldwide and also in the United States. Right now, both of them can be done at home in the United States. And that's an important thing to note. We're really transforming the way that we can take care of our dialysis patients and allow them a little bit more freedom in their lifestyle by being able to do dialysis at home. So this is just a bit of a graphic about hemodialysis. So you have the patient, and then the patient has a dialysis access in their arm. And you see 2 lines, which are like large IV lines that are leading to a filter, which is the dialyzer. And that can be considered the artificial kidney. So that artificial kidney there filters the blood. And then it does essentially the same thing. It decides what molecules are going to be put out into waste. And then the other things it puts back into the body to be circulated around to the heart. And then the other type of dialysis is peritoneal dialysis. So the peritoneum is a lining in your abdomen. And this is a very, the space is full of blood vessels. And those blood vessels in that space kind of act as your artificial kidney or your dialyzer to filter substances out of the blood, okay? In order to receive peritoneal dialysis, there's a small tube that is put into your abdomen. And on the right-hand side, you can see there's fluid bags where you put fluid into the abdomen. It sits for a while, and then you drain the fluid. And on that drained fluid is all of the waste products that your kidney's not able to get rid of, that this peritoneal space is able to filter out of your body. All right, so I throw this slide in just to lighten it up. After speaking about dialysis options, it's looking at a scale and saying, don't step on it because it makes you cry. Thank you for listening today, and I will take any questions.
Thanks so much, Dr. Kennedy, for that wonderful presentation. Please go ahead if you have questions.
I did.
I have a question.
Go ahead.
I'm sorry. So my blood test has historically shown that I have protein in my urine. Is there anything that should have been done or can be done to alleviate that?
So yes, there are medications that we use for people who we see have protein in the urine called angiotensin receptor blockers or ACE inhibitors. So there are medicines like enalapril, lisinopril, irbesartan, losartan. And these are medicines that have been clinically proven to reduce the amount of protein that your kidney is spilling. They may not necessarily completely resolve it. You might still spill some protein, but these medications can help limit it.
Thank you. I do have one follow-up. I'm sorry, because I'm a little adverse to medications. Is there anything else that can be done that you're aware of?
No.
Okay, thank you.
Okay, Dr. Kennedy, I wanted to thank you so much for that thorough presentation, especially explaining about dialysis and the time that it takes in the state of Illinois to get a kidney transplant. But I also found out when my cousin was looking for that kidney transplant, that you could go outside of the state of Illinois, you could put yourself on several registries.
Yes.
Actually in Iowa, it's only a 3-year wait. But the problem is if you go to another state to get a kidney, you have to be willing to either travel backwards and forwards for your follow-ups, which are what, how many, 2 to 3 times a week, Dr. Kennedy, maybe? I think it is. Yeah, for several weeks, like a month to 6 weeks in order to do that, or be able to house yourself and live in that state for the amount of time you would need to do follow-ups regarding the kidney. And thank you so much for mentioning the dietary sodium, because a lot of times we don't think about, oh, well, I only use a little bit of salt here and there. But if you look at your spices and the condiments you use, you see a lot of added salt, a lot of added sugar. I had a sea salt I was using and realized one day something said, read the ingredients. It said dextrose. I know that's a form of sugar. Why would a salt need a sugar added? So I had to totally switch my my salt. So thank you so much for your presentation. I really appreciate it.
You're welcome.
Any other questions for Dr. Kennedy?
Is
So
it
go ahead.
possible? Yeah, is it possible to see that slide again that had the dialysis you can do at home with the 2 tubes into the 1 arm?
I can bring that up. Give me 1 second. I'll go
Okay.
ahead and.
I just want to get a picture of it right quick.
Yeah, right now, both of the dialysis modalities are available at home in the United States. Patients really like that because it frees up their time. They don't have to go to a dialysis unit for 3 or 4 hours at a time, 3 days a week. And you can be completely trained. We don't let you go home until we feel that you're ready. Those that try it tend to stick by it. They often think it's the best thing that ever happened because they can take care of it themselves.
Yeah, that was recommended for my cousin, but unfortunately he passed away before we even got to that.
Dr. Kennedy, I had a question. I know several people that are between the ages of like 40 and 50 something, and they're on dialysis now. Are you seeing younger patients, or is this a typical age range? What have you noticed?
Yeah, unfortunately, when we think about chronic illness, we tend to think about older patients, but unfortunately, the patients are getting younger and younger. I mentioned how there weren't a lot of men on the phone call. I see so many young men who have had, very poorly controlled high blood pressure, maybe for 5 or 7 years, and their kidneys are totally gone. So yeah, unfortunately, there is no age discrimination. I have patients in their 20s that I've had to put on dialysis. It seems to be happening more frequently.
Thanks for answering that. Do we have any more questions for Dr. Kennedy? All right, well, Dr. Kennedy, thank you so much for that informative presentation. We really appreciate you taking the time today out of your busy schedule to share with us. And now we are coming to the close of our seminar today. Millicent, I'm going to have you to bring up the slides on our upcoming events. Thanks to all of you all who joined us today. To take 2.5 hours out of your busy schedules to join us, we really appreciate it. Thanks to all the doctors that spoke today. So we had Dr. Goodwin, Dr. Spicer, Dr. Johnson, and again, Dr. Kennedy. And it was such a well-rounded event in that, we could see how diabetes affects, so many things in our body. So we touched on the eyes, the kidneys, the feet, you know what I mean? And we know that diabetes can affect the heart as well, but no, thanks to all of you all. So Shakoi, of course, we focus on helping others in the community, and something that we are trying to help out more sooner would be our Thanksgiving giveaway. So we have a flyer here, but please contact us at shakoigroup@gmail.com. So if you are interested in donating, or if you have a family that you think, you want to donate to, we can help out. And so please contact us by, I think November the 17th is when we're saying, try to contact us with that. We also have another event coming up starting in January, our Creative Health and Fitness program, which we are, we're going to have a nutrition piece, and we'll also have a cooking class, and anybody is welcome to attend. And we're talking about families, singles, children. And so that's going to get started in January. The dates are still to be determined. So we will make sure that those of you who joined us today, that when we send out the email, you'll get some information. But if you want any information regarding this, please, shakoigroup@gmail.com. You can contact us on Facebook, go to our website, but we are looking forward to getting this event started. So again, I want to thank everyone who attended today. Thanks to the participants. Thanks to all of you who have listened and asked questions today. We do have a second part next weekend, and that's going to be Saturday, November the 12th, starting at 10 again. We're going to have a nutritionist, Lisa Angel Smith. We're also going to have a chef demonstrating some plant-based recipes. Her name is Chef Brandy. And then we're going to have a clinical social worker, Kimbereley Blackwell, who will talk to us about mental health and diabetes. And we're going to do some meditation as well. So please, please join us again next week. And also, we have a poll that's coming up. So please take the time before you end today, take the time to do this poll for us. We would greatly appreciate it. Are there any comments? Anybody want to say anything before we end our event today? Millicent, was there anything else you wanted to say before we end?
No, I want to thank everybody for coming. I want to hope that everybody has gotten some valuable information from today's seminars. I look forward to seeing you all back next week, same time, same place. We will have the video prepared and posted on our YouTube channel, so please check us there. And I will definitely send out an email to everyone, letting them know when everything is set up or not set up, available to view. Thank you all for your responses. I am going to leave this open. Feel free to log off and enjoy the rest of your day. Thank you so much again to all of our doctors that participated and all of our members that joined us this morning and all of our guests as well. Thank you and have a great day. Be healthy and be well.
Thank you all.
Thank you.
Thank you so much. Very informative. Thank you.
Thank you.